Department of IAPMR, SVNIRTAR, under the aegis of Odisha Association of Physical Medicine Rehabilitation and Indian Association of Physical Medicine Rehabilitation. Friends, today's topic is an interesting topic based on sports injury. Sports injury rehabilitation is an essential part of our specialty. Many of us, we ignore it whenever a patient comes to us with any sports injury or similar type of injury like ham's injury. We think about relief of the pain or to maximum gaining range of motion, but that's not the enough for a sports person. We have to think about relief of pain, achieving full range of motion. Besides that, the power, endurance, and speed. These are also important things which should be taken care of, especially when you are dealing with a person with a sports person. So today's discussion on that, we have with us one of our senior friend with having vast experience in field of sports injury rehabilitation. She is Dr. Harleen Uppal. She has done her post graduation from prestigious institution AIMS New Delhi, and her interest on sports injury is reflected from her qualification on sports medicine Commonwealth Fellowship from UK, and also she has done fellowship under this Olympic Society. Currently, she is serving as Assistant Professor, Sports Injury Center, VMMC, Safdarjung Hospital. She has more than 30 publications in international and PubMed journals, and she has received award Commonwealth Fellowship Award UK 2014 to 15, and she has also received Rehabilitation Research Award in 2019, ISPO Travel Fellowship 2012, and she has done diploma in sports medicine from International Olympic Committee. She has special interest on para sports medicine, musculoskeletal intervention, especially ultrasound guided, and neuro rehabilitation. Without wasting time, I invite Dr. Harleen Uppal for presentation on musculoskeletal ultrasound, hamstring injuries, and return to sports. Over to Dr. Harleen. Thank you.
Thank you so much, sir. I would, at the outset, I would like to thank Sir, Dr. Pabitra Sahoo, sir, Department of PMR SVNIRTAR Odisha for organizing the IAPMR webinar series and also the IAPMR, our association. So I would be focusing mainly on hamstrings injuries and then return to sports. So my presentation is basically divided into three parts. First of all, we would be covering the musculoskeletal ultrasound, the technique, how we actually do the ultrasound of hamstrings, followed by the regenerative medicine options, particularly for hamstring injuries. And then finally, as sir also said, the return to sports, particular the criterias, how we return to sport. So there are phases of return to sport and how the athlete should be transferred from first stage to the second stage to third stage. So the immediate stage, post injury, then intermediate stage, and the late stage. And there are criterias, fixed criterias, in which you can actually say that yes, now the athlete should be going to the second stage, and now he should be going to the third stage, and followed by a return to training and then return to sports. So the we should understand here that our patient population here is athletes, and athletes are very particular about, because the time here, time is everything. So everything has to be done in a evidence based, scientific based manner. And athletes are also very educated, and like they are, sometimes some athletes are knowing more than us. So we learn a lot from them as well. So that is why when we deal with them, we should read our literature. We should be and they cross question you. They will say, why are you doing this? Why this exercise and why not this exercise? So in that way, and we have to be very much knowing everything. So as I said, if one of us gets an opportunity to be on the field and we are the field doctors, so and there is an acute hamstring injury, then what do we have there? So we have all our the basically the price which we do, um, rest, compression, ice, elevation, that is there. And plus we need to diagnose the injury. So diagnosis is important, whether it's a back injury or a hamstring injury. And here comes the role of point of care ultrasound. So if we have ultrasound nearby to the field, nearby to the training area, and we can quickly diagnose our injury, and then it would be really a gain for the athlete. As for him, you have actually saved so much of time. So time is everything for them, right? Now, if we just see some of the epidemiology, um, so what is the highest number of matches which have been missed are because of hamstring injuries. So this is if two, three things which we should know in sports injuries, I would say after knee, shoulder, hamstring is something which we should be very much thorough with. So the Aspetar, which is a world-renowned hospital having athlete rehabilitation services and sports medicine services, they have done a study, and they, according to their study, 20 per season per club is an average of matches which the athlete has lost because of hamstring injury. So it's quite a big number for them, because even missing one match is like everything for them. So uh, then sprinting is the main mechanism here. So mechanism of injury is also very important in hamstring injuries. And most commonly when a footballer is running and running to kick, so he is sprinting. That is the most common form of injury. Even runners, once they are sprinting, so the fast runners, 100 meters, 200 meters, they get these injuries more. Then the second common mechanism is when a goalkeeper is trying to save the ball. So he stretches his leg, and that is when he might get a hamstring injury. So mechanism is important, because if you are on the field, so you would know that yes, this is not a back injury, this is not a knee injury, it's a hamstring injury. Definitely he would be holding his hamstring, but still mechanism is important. Then comes the which hamstring is most commonly injured. According to the studies, it is the long head of biceps femoris, which is most commonly injured um, in uh, like trainings. So why do we need a point of care ultrasound or an ultrasound just nearby to the field? Or you can say just after he is injured, he should be taken to a point of care ultrasound. Why? Because you cannot get an MRI straight away. There is a lot of edema there. X-rays won't tell you anything. He's in a lot of pain. And yes, posterior thigh ecchymosis you would see. So POCUS, I would say, is something which, if not better than MRI, it's very much useful. Now, one or two slides about prognosis of injury. So if there are different areas where the hamstring can be injured, just near to the ischial tuberosity, that is the where the conjoint tendon is there, from where the hamstrings originate. There it is a very common part where hamstring is injured. And if you say that prognosis, it takes a long time for return to play. So the athlete will ask you, how much time will you be making me ready for the match? And he actually asks you, can I play in a month? Can I play in 2 months? So we have to be very clear. We have to tell him where strict timelines. So if it is a proximal injury very near to the ischial tuberosity, there will be a longer return to play. If the size of the strain or tear is more, it has an association with recurrence of injury. So if it's a big tear or a big strain, then you can even guide the athlete that if you don't do a proper return to play rehabilitation program, there might be an recurrence, because once it recurs, he will come to you and he say, "Aapne mujhe theek nahi kiya. I have got another again the injury has come back." So if you have already told the athlete, then it's that is what should be done. So as I already told, ultrasound is at least as valid as MRI for the evaluation of hamstring strains. Now if athlete asks you, do I need to go for surgery? Then again, you should be knowing that most of the hamstring injuries, if there are grades, there are grade 1, 2, 3, 4. I will talk about them based on the MRI grades. But if it's a rupture, if it's a grade 4 injury and the entire hamstring has avulsed from the ischial tuberosity, then definitely he should be going in for a surgical repair if it's a complete avulsion, right? And it's very common in dancing, weightlifting. We don't have much ice skating, and water skiing also is less in India. So these are the complete avulsions. And what is the mechanism here? It's an eccentric contraction with the hip flexed and knee extended. So that is when the athlete might get a complete rupture, and then he should be straight away told that it's a surgical repair is indicated. So the slight anatomy. If you can see the two heads of the medial hamstrings and the lateral hamstrings, we have the semimembranosus and the semitendinosus on the medial side, and the biceps femoris long and short head on the lateral side. I'll not go much into the anatomy, as that will waste a lot of time. So here, coming to the first part, which is the specific ultrasound reference points. So once you start scanning the hamstrings, these are a few of the reference points which you should keep in your mind. So tendinous origin of the hamstrings. So you can go either from distal to proximal or proximal to distal. It's totally dependent upon you and your preference. So once you start doing the hamstrings, you will make up your own protocol for this. And I would like to say that in a lot of cases, not only athletes, in a lot of our recreational players also, patient presents with a thigh pain, you must definitely examine him for a hamstring injury, because these are very common and easily missed also. If as the Gray's Anatomy also says, if our mind doesn't know, we just tend to miss it. So that is the aim of this lecture which I'm taking, that hamstrings injuries are very common, they should not be missed. Put your ultrasound there and just see tendinous origin. You will see the proximal half, you will see the distal medial half and the lateral half. So this is the inverted tuning fork protocol, which is followed usually in ultrasound scanning, and it's basically the anatomical landmark. So this is the tuning fork handle, which corresponds to the common tendon, and the sciatic nerve is just behind it. Once you come to the prongs of the tuning fork, you will see that the medial hamstrings is on the medial prong, and the lateral hamstrings, which is the biceps femoral long and short head, are on the lateral prong of the tuning fork. And here, right at the junction of the handle and the prongs, you will see the Mercedes-Benz sign, and you will also see the sciatic nerve. So I'll show you that picture. This is again just more uh, so that you can understand the anatomy clearly. Once you have actually dissected it, you will see the biceps femoris and the semitendinosus, semimembranosus like this. So a thing to be noted here is that once you start scanning from distal, you will first see the semimembranosus muscle. As you can see, it's muscular distally, and then you will start seeing the semitendinosus belly, right at this place. Once you're scanning from distal and you're at the middle of the 1/3 and proximal 2/3, somewhere here, you will start seeing the semitendinosus, small muscular belly and tendon coming up. And then as you go up, you will again, the semimembranosus, you can see as you go proximally, the muscular part decreases. So muscular part is only in the middle part. Then again, you get the tendon. And where the semimembranosus tendon is there, it corresponds to the semitendinosus muscular structure. So, and in the middle of the semitendinosus, you can easily see the raphe also. So this is very clearly seen once you go from distal to proximal on the scan, and you see a curtain-like appearance. So because once you scan the semitendinosus from here to here, this raphe comes and it looks as if a curtain is going there, right? Curtain is closing up. And so these are the short and the long heads. So distally, you will see the short head first and the muscle belly first of the short head. And as you go proximally, you will start seeing the long head. So, and this is the area of the conjoint tendon proximally. So this is how, just to make the ultrasound easier for you. So there are a few studies and different people have different approaches to the scanning. So Jacobson says that you start from medial side, and there is a triangular section of semimembranosus along the short axis, and in the lateral direction, you will see the semitendinosus and biceps femoris. Bianchi and Martelloni, they say this semimembranosus in a short axis plane, moving distally, semitendinosus, and more laterally. There are different regimes, but according what I practice is you go from distal to proximal, and it's a very clear picture which you get. So this is the Mercedes-Benz sign once you are on the proximal part, and you can see just this is the sign of the Mercedes-Benz, and it's here. Right. So what we can see here is that this is the semimembranosus tendon. The tendon of semimembranosus actually starts from here, and then it's a circular part, and then it again goes up to here, up to the Mercedes-Benz. On the lateral side, you see the biceps femoris. On the medial side, you see the semitendinosus, and this is the conjoint tendon. And here you see the sciatic nerve as well. Right. So this picture should be clear to everybody, as this is a very common area where injuries occur. So common tendon, the conjoint tendon, what you will see is this sharp demarcation actually becomes blurred, and there is a lot of edema there. There will be change in architecture there. There will be hypoechogenicity. Sometimes the fluid is there, and there can be hyperechogenicity as well if it's a long history and there is some fibrosis which has happened there. So these are the scan. If you have put your probe on B and C, so the picture which you will see is here, biceps femoris. So this was the curtain-like appearance which I was talking about of semitendinosus. So this you will see once you are scanning the semitendinosus from distal to proximal. So this is the approach which you can try. So this is from distal. Once you are on the distal part of the thigh, what you will see is a semimembranosus muscle and the semitendinosus small part, because the muscle has started to come. Right. First you will see the tendon, then you will see the semitendinosus muscle which has started to come. As you go proximally, you will start seeing the semitendinosus being bigger, and it actually covers most of your screen. Semimembranosus will become smaller. On the proximal part, you will see it semimembranosus as a comma-shaped muscle here. So this is the semimembranosus muscle and the semitendinosus, which has become quite big now. And this is the raphe also, which once you scan, you will see it as a curtain-like appearance. And as you go proximally, the semimembranosus will become a tendon. And it's this part, which is the tendon. So again, it's just a cut section. What you will see if you put your probe here First, you will see the semi tendinosis on the medial side, then on the lateral side, and then as you go medially, you will start seeing the semimembranosus, gracilis, and then comes the sartorius. Then we have the vastus medialis. So the anterior thigh structures start coming up. And this is again the same thing. I'll not again and again tell. So it's right. So above system is based on the ecographic landmarks that are often situated in the intramuscular structures of hamstrings or the sciatic nerve, basing the examination on relationships between muscle masses. That is what these two scientists had said, that muscle masses, as I told you, that at one part the semimembranosus will appear very big and semitendinosus small. So this is how the techniques are there. The sonographic landmarks, it's a good paper if you want to read about it and just improve your sonographic skills of hamstrings. This is the proximal ischial tuberosity, as you can see, and yeah, there is a tear, right? This is the tear part, and you can actually inject in this area, and this is on the cut section and on the cross section and the longitudinal view. And there's another picture of a semimembranosus bursa injection that is also very commonly found. And if you know that it's something like this is there, then you might be actually diagnosing these in your patients. And this is how the ultrasound guided technique is. So this is the semimembranosus bursa which is there, and you can do an ultrasound guided intervention. You can actually put some small amount of steroid in here to relieve the pain. So this is how you can do the ultrasound guided techniques. Now this is the classification on MRI. So how you grade your hamstring injuries is important, because your management line will depend on the grade of injury. If it's on MRI, if it's a grade 0, that is MRI is normal, or there is patchy high signal in one or more muscles. Grade 1 is a small tear, that is high signal cross section in less than 10%, and that length is less than 5 centimeters. Grade 2 is a moderate tear, grade 3 is an extensive tear, and grade 4 is a full thickness tear. So less than 10%, 10 to 50%, and more than 10%. Again, grade 3, all the grades 0 to 3 can be further graded into A, B, and C. A is a myofascial injury. B is if the muscle and tendon both are involved. And C is if it's an intratendinous injury. So this it's also called as the British Athletic Muscle Injury Classification, BAMIC. This you should be knowing. Then, so what are the regenerative medicine options if we have an acute hamstring injuries? So this is a good paper. You can read it. What basically the gist of many papers is that platelet-rich plasma is a good regenerative medicine option which we have, but it should be given in the acute phase when the muscle injury is very new. So that is what again re-emphasizes the early diagnosis. If you give the PRP in the 0 to 7 days period, or maybe 48 to 72 hours, quite early, the chances that the injury will heal, the muscle injury will heal, are much more. So there are studies in favor of this statement. And further, as you people are aware that there is leukocyte rich and leukocyte poor plasma. So what actually should be given? There is again a very hot debate about it, but leukocyte rich plasma has more role in muscular injuries, as everybody is aware. So here again we have quite a lot of papers saying that leukocyte rich PRP should be given in muscular injuries. And if it is a tendinous injury, if the injury covers the tendinous part, then you can even go for a leukocyte poor PRP. So this is just a comparative view of which PRP should be given. And there are a few RCTs which have been done regarding this. And so leukocyte-rich PRP, in majority of the cases, they have found it to be, even in, there are some animal model studies also in humans, then in athletes, they have done quite a few studies, and or most of them, it's leukocyte-rich PRP. However, a few have also said that leukocyte-poor PRP is good. Then, so now we come to the third part of the presentation, which is more oriented to return to sport and return to play. So you can see here, there are stages which after the acute phase has gone, after maybe you have gone for intervention, or maybe you have not gone for intervention, maybe you have just given him a conservative management if it is a grade 1 or a grade 2A injury, and you decided to give, because conservative management is also quite helpful in such patients if the PRP is not available. But if PRP is available, you should definitely go for it in the early part. If the athlete actually comes to you in the early part, first 7 days of injury. After 7 days, it would not be of much use, because you know that it's the regenerative phase in which if you give the PRP, it will be helpful. So there are stages after you have now telling the athlete that now rehabilitation should start. So stage 1, stage 2, stage 3, these are the in the clinic phases, and on the field phases are stage 4, 5, and 6. So what is the criteria? For shifting from 1 to 2, it's a painless single leg squat. I will go into these details right now. So, but just a gist of it, that painless single leg squat, and if the athlete is able to do a painless cycling at 150 watts for 5 minutes, this is very specific, then you can go for stage 2. Again, if the athlete is able to run with more than 70% of his effort, and the range of motion, if you check with an SLR, it is pain free. And if you check the hamstring strength with a handheld dynamometer or an isokinetic dynamometer, it's more than 75% of the normal limb. Then you can go to stage 3. And then from stage 3 to stage 4 is when 100% running, he's able to give his 100% effort on running. There is a painless direction change. Again, if a direction change is painless, you can go to football training. So this is specific for football, as most of the hamstring injuries occur in football, and most of the studies have also been done in footballers, if you see the literature. And so stage 4, light football training, you can start. Then again, you can start with an in-between football training session in stage 5, and finally going to a stage 6, which is a heavy football training. So here, it's more of criteria based rather than time based. This is another thing which should be told to the athletes. Here, the prognostic factors are there. So I'll just say the gist of it, that slow stretch type, if the injury mechanism is a slow stretch type or a sprint type. As I told you that there are two types of most common injuries. So slow stretch type takes longer time for recovery. Then return to play is shorter when estimated. So if no, we'll go for this one. Yeah, flexibility deficit measured with the passive SLR test. So once you do a passive SLR test, you check the flexibility of the hamstring. It's if it is more, if the deficit is more, then again there will be a longer time to return to play, and time taken to walk pain free is also very important. So again, if it takes more than 1 day, means the return to play will take longer time. So these things also, if we know, it will be very good. Now, so 0 to 7 days, what all exercise protocols you will tell your athlete for? So activation phase, this is divided into 3 phases: activation of the muscle, loading of the muscle, and overloading of the muscle. So first, you definitely activate that muscle. So you have to activate the hamstrings. For how you will do it, you will do an isometric strengthening exercise, and you will go for isometrics in the lesser range, and then you will again go for range of motion exercise. Then you will put the athlete to bike. You will tell him to do a static cycling, and you will also tell him that you can walk. So walking gait is also checked. It should be pain free. Then in the 0 to 7 days, it's very mild exercises you're telling him. You progress to the low, and you also tell him some loading exercises. So you basically tell him the diver, glider, and extender stretches of hamstrings. I didn't have the good pictures of these, but you can search them in the internet. It's very nicely given. The loading phase of hamstring, it is divided into diver, glider, and extender stretches. So in the initial phase itself, you can tell him the L protocol. This is called as the L protocol, and it has 3 stages in it. Then so activation, loading, and don't forget that you need to train the other areas of the athlete as well, because in this wake that his hamstring is injured, he will actually decondition his upper body, his core, and that is all very important for him to return to play. So while his hamstring is injured, the other areas should be trained in the gym. He should be doing his calves. He should be training his adductors, rectus femoris, abdominals, hip extensors, hip abductors, only sparing the hamstrings because we are going for a specific protocol for hamstrings. But other things, he should not stop going to the gym. He should be training all these. And this is cross training. So cross training is very important. How you will actually progress to the second stage, there are some criterias which you check. So you ask the athlete to go do a single leg squat. If it's a painless single leg squat, and if low resistance high cadence bike is painless, so you are telling him to do a cycling and at a very low resistance because you're still at the first stage, and at high cadence. If it's painless, you can now easily say that yes, he can progress to the second stage. Just a picture of how you have to tell to do a single leg squat. So this is a 45-degree single leg squat, and this is a bench height. So what you do is you tell the athlete to squat and go up to 45 degrees. And the important thing is that the feet should be at the shoulder width. So width of the shoulders and the width of the feet should be exactly same. And also knees should be directly in line with the feet, that is the second toe. So the direction of the knee should be in the direction of the second toe, and upright, the upper body is maintained upright. So how it is done is also very important. Then the intermediate phase, which is 2 to 14 days, in which you will now focus more on loading. So you had already activated the hamstrings. Now what you will do is you will tell that now start slow running. So he will start slow running. He will start running drills up to 70% of maximum effort. So never 100% at this early stage. It's maybe 50 to 70 depending on pain. So you have to tell him that pain he should take as a guide. Whenever pain is less than 3 on a VAS scale of 10, that is muscle soreness. If it is more than 3, it means that that exercise should be stopped. Also, the following day is important. Following day, is he pain free or does he have pain? That is very important for the athlete to check whether he is on the right rehab protocol. So in the loading phase, you will tell him to do a running drill of up to 70% maximum effort. You will start Nordic hamstrings. So Nordic hamstrings, everybody knows, it's eccentric training of the hamstrings. And you will start a Romanian deadlift, straight leg bridges, or deadlift is again important because here again all these things are deadlift, bridge, all are closed kinetic chain exercises. We have started with closed kinetic chain, and then some of the open kinetic chain also have started, like a 45-degree hip extension. Straight leg bridge is started because it is more of core which we are training now. So we have covered everything. We have started aerobic training for him. We are loading his hamstrings. We are doing some core exercises, and we are also doing cross training for the other muscle groups. This is how a single leg how you progress with a bridge, which is an important core strengthening exercise. So this is a double leg bridge, and then you go to single leg bridge, and with another person's help. That's the third stage of a single leg bridge. Then this is how you do a Nordic hamstring exercise. Once the hamstring is recovering, Nordic hamstrings should be initiated. This is a NOR board. If you have the facility of a NOR board, it's good. Otherwise, even without a NOR board, you can do a simple Nordic hamstrings. And the athlete is then instructed to, what it's done is that ankles are fixed in these stirrups, and the athlete is instructed to fall forward and resist the fall to the ground for as long as possible using his hamstring muscles. So you must have seen this, that many athletes do this as a part of their prevention of injury program also. So prevention of injury is very important, and Nordic hamstring is something which is there in a footballer's prevention regime as well. And how you progress to the late stage, if the athlete is able to run more than 70% of the perceived maximum, you can say that now he can go to the last stage, which is again, this timeline is not very fixed. It depends from athlete to athlete, from injury to injury, and from like how much time the athlete is taking to progress from one stage to the other. So it is more of criteria based. Activation, in activation you have started slow running. In loading you have started running and running drills up to 70%, or most of the same exercises in the last stage, but this is extra. Now you actually overload, or you do resistance training for the hamstrings. So you initiate fast running, with direction change, then acceleration to fast running, and then sprinting longer distances, and you also start some sport specific running and loading. So depending on the sport of the athlete, if it's a football, you start some football drills, you start some of the FIFA 11 drills, and if it's a tennis, you start the tennis drills. So it's like that. It should be sport specific after this. So what is the criteria to progress to training? So when would you say that yes, now you can go to your training, you can start doing your training, but that too in a graded manner? When there is painless maximum effort on running, good recovery the following day. So following day is a very good guide for the athlete to see that his rehab is going on the right track or not. It should be a good painless hamstring the following day. So his thigh should not be very sore the following day. Painless maximum effort direction change. So when he changes the direction, it should be painless. Again, good recovery the following day. Painless maximum effort acceleration. So when he is doing a maximum effort, 100% effort, he's giving an all out, then it should be painless. If he has demonstrated volumes and intensities of fast running required for the individual, and you palpate, there is a painless palpation. So these are the criteria. Then you do the restoration of hamstring strength. So here it's an important point, the second last point, that you check the strength of the hamstrings. So many of you might be having a handheld dynamometer. If you don't have, you can actually buy it. It's a very small device. I'll show you a picture of it, and it can be kept in your clinic itself just to check the hamstring strength, which is important for return to play decisions. And if you have an isokinetic machine, it's the best. So if you check an isokinetic strength, and there what you check is you check it with the uninjured leg. So you have to compare it with the uninjured leg, and you have to calculate the limb symmetry index. How a limb symmetry index is calculated, you actually put the injured leg hamstring strength on the numerator, and in the denominator you put the uninjured leg strength, and then you you take out a percentage of it. So that is how a limb symmetry index is calculated. It should be more than 85 to 90%. So the strength should be mostly equal to the uninjured leg. Or if you have a previous normative data, depending on the position of the player. So if it's a defender, or if it's a goalkeeper, it depends. So there, if you have a normative data, which is very less for Indian data, then you can actually compare it with the normative data also. So pain-free full range of motion is again a criteria which should be met. This is a handheld dynamometer, and it comes in different models. So this is how you check the strength of the hamstrings. You take 3 readings and you take an average of it. It can be very easily done. So yeah, I think I'm done with my presentation. think I'm early, so I can take up a few questions.
Thank you, ma'am. Let's see, is there any question in the chat box? We'll see. Go ahead accordingly. Just before taking our question from the participants, few questions from my side. That why the long-headed bicep is very often injured, because most of the time you see other conditions where we target medial hamstrings often, and that spasticity, gait abnormality are mostly from medial hamstrings. And when you go for gait assessment also, we target medial hamstrings more than lateral hamstrings. So what's the reason why lateral hamstring is so commonly injured than the medial hamstrings?
Right, sir. So, in my practice also, I've found even medial hamstrings to be a very common injury. And I would say in my practice, I've seen more semi-membranosus injuries and more semi-T injuries. But maybe I have not seen that much of hamstring injuries. If you go through the literature, it says that biceps femoris injuries are more common. And it's also logical if we see this diagram, the cut model, the semi-membranosus and semi-tendinosus, it's a very strong, together they form a very strong hamstring bulk. And as we all know that even in ACL tears, they take a graft from semi-T. So they actually, that's because the medial hamstring is a strong hamstring group as compared to the biceps femoris, which is a even a, which is a smaller, with, like, you can say, a less bulkier muscle group. So as per my knowledge, I would say that this bulk and semi-membranosus, semi-tendinosus together, they constitute a bigger muscle group. That is why they are less often injured. So and the data is something like 80% injuries are more common in biceps femoris. These are again international data, so we cannot actually extrapolated to Indians, because the anthropometric measures of Indian athletes is different. But since studies are limited for Indian athletes, I have taken the international epidemiology data, and that says that 80% is biceps femoris, then comes semitendinosus, and then we have semimembranosus, around 20% and 10%. So some percentages are like that. But what I can understand, and from my experience, it's definitely when we even keep the ultrasound on the hamstrings, we see a bigger bulk of semimembranosus. And if we compare it to the biceps femoris, it's a very small cross-sectional area. So that I would say would be the reason that biceps femoris is more common.
Is this injury a sports specific? I mean, when we talk about the athletes of cricket player or versus a football player, is there any sports specific injuries, medial versus lateral?
Medial versus lateral sports
Hamstrings.
specific, yes, I would actually tell about my experience. So because Indian data is less, and what we usually see is in practice is that mostly footballers come with hamstring injuries, then followed by runners, athletes, like these field and track and field athletes, they have hamstring injuries very commonly. And then cricket, I would say, have less of hamstring injuries. They have more of back injuries because of that bowling action. So, sport specific, I would say that hamstring is more common in a particular sport. But if we categorize biceps femoris and semimembranosus, the data says that biceps femoris is more common in most of the sports which have hamstring injuries, like footballers and runners. So data is something like that. But yes, you rightly said that it is hamstring is a sport specific injury, and it is more commonly seen in a particular sports.
Okay. Regarding the regenerative medicine part, use of PRP. So, how frequently is it a single dose, or it is multiple doses are required depending upon the gradation of injury of the
Right,
hamstrings?
sir. I think I missed that slide. Yeah. So this is a very good question, sir. Very relevant. So there are in my practice also, and the studies which I have read. So first injection is usually given in 48 to 72 hours after injury. That is the early regenerative phase. If the athlete is coming to you, then if you are seeing a grade 2A injury, usually it is advised that you go for 2 injections, and the second injection is administered after 7 days. So it depends on the practice, but the literature which I've seen, and in my practice also, I follow this. And so we cannot do this MRI, but the grade 2 and grade 2C injuries, they say that it's 3 injections are usually advised. So if the myofascia is only involved, if the muscle and the tendon is involved, or if the tendon is involved, depending on that, usually the number of injections are being decided. But usually I go for only 2 injections, and that is spaced either like 7 to 14 days after the first injection. I go for another injection, and that is how I practice.
Okay, one question from one participant. He's asking about what fellowship options are currently available for sports medicine.
So there is a this International Olympic Committee Sports Medicine diploma course which you can do. Then again, there is a FIFA Sports Medicine diploma course that is also available to most of like it's accessible online, that you can do. Apart from this, there is a post MBBS the diploma in sports medicine which is undertaken in Sai in Patiala. So that is again a diploma which is NMC recognized also. So that is another option. But that for that a NEET PG has to be cleared, and it you get it through that. And apart from this, I think the options of fellowships are limited for post PMR. So these are there are a few fellowships which are FNB sports medicine, but it's for the orthopedicians. So that's how these three things can be done.
Yeah. Next question, what is the use of registered isometric testing if USG is not available?
Right. So, isometric testing is very important. Like as I showed you the handheld dynamometer, if you don't have a what do you say, an ultrasound scan, and if you have a handheld dynamometer, I would say yes, handheld dynamometer is also equally important equipment. And you can once, because once you're returning the player to sport, you need to actually know the strength, and you need to compare it with the normal strength. You need to calculate the limb symmetry index. If it is more than 85%, 90%, then only you can actually return him back to sport. So that way, resisted isometric strength testing is more important for return to play criteria. Ultrasound has a different, it's for the diagnosis and for the intervention. So both the things have different indications.
As far as the limb symmetry index is concerned, is it the only power is taken for comparison of with a healthy side or a healthy limb, or any other criteria also used?
So
Only power criteria is taken compared with the healthy side?
yes. So best is if you have a normative data. If you have a baseline data for that particular athlete, how his what his hamstring strength was before injury, which is very difficult in Indian scenario. We don't have our normative data. But if then in that case, what we do is that we actually check with the opposite limb. But again, here the factor which is to be kept in mind is that he might be the dominant limb is different, so the strength will be different for the dominant and non-dominant limb. But still, since we don't have a baseline data, if in our clinical scenario, we have nothing else but to check with the opposite limb. These are the two options.
So one interesting question, how to decide the dominance of the limb for the lower limb?
It is there is a dominance for the limb for the lower limb also. So if you see in a cricketer, the landing leg, that's the dominant leg. So it's sport specific. The kicking leg in football is the dominant leg. So it's like that. The limb with which the footballer will kick. So if I am kicking, I will be kicking with my right leg. It's different for different people. That is how you decide. So it is sport specific.
What is the recommended frequency and duration of prescribing physical modalities in acute hamstring injury?
You can go for physical modalities, but evidence is less for them. So, in my clinical practice in my center, we usually give ultrasonic therapy, we give laser, probe laser, and scanning laser for healing. So, these are for healing. And then pain management options, you can go for IFT and TENS. But again, if you have to give any two things, give one for healing, like ultrasonic you can give, and plus one of the pain management if the pain is too much. That is how we decide, depending on the mechanism of our physical agent modality. But literature is very less for acute hamstring injuries and physical modalities.
In case of acute tear, somebody is asking, in case of acute tear, ideally, how many sessions of PRP injection is needed and how many days does it take to recover roughly?
Right. So as I showed in the lecture also, the roughly 28 days is what if the athlete is going according to the rehab protocol. If he is from one criteria, from one stage to the other, if he is properly going as I showed, it is 28 days roughly. But it depends athlete to athlete if he is actually following the rehab protocol properly. How big is the injury? That also, if it's a bigger injury, it will take more time. If it's more towards the conjoint tendon, it will take more time. So all those factors will depend your the time of injury. That is why I would say it is criteria based, but roughly 4 to 6 weeks is the time of a grade 2 injury for healing if properly the rehab is followed. And number of injection, the other part of the question. So if it's a grade 2, you can go for 2 injections, either 7 to 14 days apart. Or if it's a grade 2C, like your even the tendon is involved, you can even go for 3 injections at the interval of 7 days. And it depends on the availability, on the costing. So many factors are there which come in our clinical practice. But this is the thing which is the standardized thing, that you can go for 2 injections, and you can even go for 3 if it's a bigger like grade 2C or 3 injury according to the MRI.
In your practice, do you stick to the criteria of leukocyte rich or leukocyte poor for the tendon injury?
Yes, so we stick to it, and we try to make specific PRP only with leukocyte rich or leukocyte poor, because it's the indications are different. So if we don't get results again, it's because we are dealing with athletes, so we have to have that facility. So we make it in our PRP machine only, and but we now maybe somebody will ask about the growth factor concentrates and the hyperacute serums which have come up. So they are also given in our clinical scenarios. But since not many studies are there on GFC and muscle injuries, so I cannot comment on the standardized care, but we are also giving GFCs and HAS there.
So what is the cost of that kit in comparison to PRP? What is the cost of this new?
So what we have is a 35, it's around 3,000, 3,500 cost for the GFC and HAS. And also the PRP kit we have is a doctor PRP kit, which is again for around 2,250 or something. So that kit cost is which the patient has to bear.
Okay, suppose somebody has undergone a surgical repair for a grade 3 or complete avulsion of the hamstring tendons. Is there protocol changes post-surgical
No.
cases?
Protocol for return to play will become more delayed. So initial immobilization phase will have to be given, but after that, this protocol will again come into play. So this protocol will have to be made for a surgical repair. This is for a conservative care, which I have showed. So the stages will remain same, but the time will increase.
By clinical examination, can we decide the grade of injury, hamstrings?
You
By
can
clinical
by
examination.
yes, to some extent, you can decide uh, whether it's a shorter. Actually, in the clinical examination of hamstring, you should be checking the palpation is important. So you actually check from the ischial tuberosity how much length down the tenderness is there, and you also should be measuring that dimension, how, because that is what, if you don't have an ultrasound and you want to decide on the clinical examination, that will tell you how big the injury is and what you should go. So to some extent you can actually decide with clinical examination.
What would be the approximate time for return to sports in partial hamstring, semi-membranous and tendinous ruptures injury?
So partial hamstring is again grade 2, grade 3 according to BAMIC, and they will take around 4 to 6 weeks. The same protocol which I have shared. That is, again, it depends, as I showed it depends on the athlete to athlete, and the so you said that partial injuries, na partial injuries will also have 2A, 2B, 2C and grade 3. So again, if it's towards the 2C and grade 3, it will take longer than 6 weeks, but on an average, it's 4 to 6 weeks.
Okay. So one last question. What is the scope of specialization in sports medicine post MD PMR in India?
Very good question. So scope, you will have to find the scope, because definitely sports, in sports, PMR is the PMR specialists are not there. So you will have to actually do the specialization and take out your clinics. That is how the scope can be made. And in federations also, it's very difficult to get in. So that goes again, like through resources, and that there are a lot of criteria which, if you will be able to go into the federations or not. So that I cannot comment on, but yes, scope you have to actually find out yourself, because right now there we are not much into sports. So people will have to start doing uh, sports injury managements, and that is how the scope will build up.
Thank you very much, ma'am. There's no more questions in the chat box. We can conclude the session. At the end, I must thank you from core of my heart that you have accepted our invitation and presented a nice talk on the sports injury. We expect some more talks from sports field, since you are working the sports injury center. So in future also we expect some more presentation from your side. And I must thank the PR team and the IAPMR, our association, providing us this Zoom platform for organizing this monthly academics webinar. I must thank all my friends of my department and all office bearers of our state association for encouraging us in organizing this webinar. Thank you very much. Thank you, everybody.
Thank you
Good
so
night.
much, sir, for the opportunity. Thank
Thank
you.
you.